Okay, so we have volleyball. Volleyball has injuries associated with that, and as we are playing, obviously we always need to do warm-ups and preventative measures to try and keep from the injuries happening. But the following will be some of the examples of injuries that could occur. The first we're going to look at is a knee injury, anterior cruciate ligament tear. And the anterior cruciate ligament is a ligament that runs in the middle of the knee, along with the posterior cruciate ligament, which keeps the femur and the tibia alignment for range of motion within the knee joint. The mechanism of injury for this would be changing direction rapidly. Anytime we change direction rapidly, this puts force on the knee because our weight is obviously moving in that direction. We're trying to stop it. So the force is applied to the knee, causing that tear. Stopping suddenly, again, we're trying to stop our weight in a position very suddenly could cause a lot of force and pressure to that ligament. Slowing down while running. This is, if you know, example would be like we did a sprint and at the end you want to stop. You have a lot of stomping and trying to lean backwards as you are slowing down. This is putting a lot of that body weight and force on the knees. Could cause that ACL tear. Landing from a jump incorrectly, putting our knee in a bad position as we are landing, this can cause that tear to happen as well. And then direct contact or collision, which we don't see very often in volleyball. However, example would be in football when a defensive player hits another player from the outside of the knee, causing that trauma to the knee and a tear possibly of the ACL. The anatomy, we look at the anterior cruciate ligament as being this ligament that runs in the middle of the knee. When we think of the knee, we got to understand that it doesn't just a flat surface that rotates through a range of motion or um, uh, flexes and extends from there. It actually has space in the middle where the ACL and the PCL run. And both of those hold the femur and the tibia in place to go through those range of motion without them falling out of the joint. Assessment for this anterior draw test and the Lachman's test, they're both very similar except for the anterior draw test, the knee is at a 90 degree with the foot planted and we are pulling forward towards us anteriorly of the tibia to check for movement in the knee joint. The Lachman's test is very similar, however we have to place a hand on the femur and the tibia to check for that movement because the foot is not planted and the knee is only in a 15 to 30 degree placement for that test. The next will be the ankle sprains. We have an eversion sprain and we have an inversion sprain, and this is going to, dependent upon the sprain, we're going to affect different ligaments of the ankle. When we look at this, the eversion sprain is going to be the medial portion of the ankle, which we see here, and the inversion is going to be the lateral portion of the ankle, which we see here. And this affects the ligaments, as you see on this side, the lateral view. We have the talofibular, calcaneofibular, and the anterior talofibular, which are the three affected by an inversion sprain. Mechanism of injury would be rapid deceleration. If our foot is in a bad position, causing it to be in a weak point for the ankle, we could see a possibility of what we call rolling an ankle. And that could also happen with landing on another person's foot after a jump. So as you're coming down from the jump, catching the inside portion of your foot, causing the inversion sprain, or we could have a possibility where we catch the lateral side of the foot and have an eversion sprain. Most commonly we have the inversion sprain. That side of the ankle tends to be the most affected. Most common is the inversion sprain, as I said, causing damage to the anterior talofibular, calcaneofibular, and the posterior talofibular ligaments, all of which connect different portions of the ankle. The anterior talofibular is going to connect our talus, which is the center bone that kind of connects all the parts of the ankle and the foot, to the fibula. The calcaneofibular is going to be the ligament that is going to connect the talus and the calcaneus, which is our heel bone, and it keeps those in place within the ankle. the posterior talofibular ligament connects the posterior side of the tibia and the fibula to keep them in place as they move through their range of motion within the ankle. For this, we have the anterior draw test, which you see here, holding the tibia, pulling the ankle forward with the hand at the ankle, or excuse me, the heel, and moving that forward. The prone anterior test is very similar, except you're laying flat down, face down on the table, and you're doing the same thing, pushing from the heel forward or down towards the ground at this point, which would indicate movement in the ankle and help us to assess this injury. Exterior rotation is this picture here, where we are grabbing at the heel and the front portion of the foot, rotating external. And then all of these are basically testing the integrity and the stability of the ankle and giving us an idea of what the next steps need to be in this process. Shoulder injuries are another big portion of volleyball because we always have our arms above our head for the different hitting, blocking, serving, setting. All of these could be putting our shoulders in very bad positions for force to be applied. So within the shoulder, you have your rotator cuff here as the humerus comes up, and you have the tendons, ligaments, which all join right at the top of that, creating the rotator cuff, and all part of that glenohumeral joint that we would be moving through ranges of motion. Mechanism of injury, as I said, the blocking, hitting, serving, and setting, all of these putting our arms above our head and in a more vulnerable point for injury to occur. The anatomy of this, we're looking at the muscles associated with the rotator cuff being the supraspinatus, infraspinatus, teres minor, and the subscapularis muscle, all of which help to rotate the glenohumeral joint or the rotator cuff through ranges of motion. When we put our arms above our head, all of these muscles are creating that motion to get our arms in place, and when they're put in those positions, it stretches everything to the point where extra force applied can create injury upon all of that, the rotator cuff and these muscles that are associated, because we're applying force to them outside of their normal range of motion. So we'd be doing aptly scratch tests, which is checking for range of motion, moving our arm through various different positions, checking for, again, the pain associated with those injuries. Supraspinatus tests would be lifting arms against resistance. If we're feeling that there's an injury, we'd have somebody apply some resistance to the lateral side of the arm as we try to abduct to the outside. Infraspinatus, a teres minor examination, which is to externally rotate against resistance, and again, this would be keeping our elbow flexed at a 90 degree, and as we have it flexed at 90 degree, we're doing an external rotation with somebody applying a resistance to the wrist area to see if we can go through that range of motion. This again is testing for injuries to the rotator cuff and the muscles associated with those movements. These would be three of the main injuries that we would see in volleyball. I hope this is helpful as far as understanding a little more of the anatomy of those, the shoulder, the knee, and the ankle, so that we can better understand how to prevent these injuries from happening through stretching and proper warm-up.